Good afternoon, everyone. My name is Rita Gaid, and I'd like to welcome you to our first 2023 quarterly educational meeting hosted by the Southeast chapter of SCCM. I have the pleasure of serving as the president of the chapter this year, and we are excited about our events that are upcoming. So I'd like to review a few upcoming events with you, and then we'll go ahead and introduce our wonderful speaker, Dr. Bookstaver. We always start our meetings. Over here. We always start our meetings by going over our mission and vision. So the mission of the Southeast chapter is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. Our vision is that all critically ill and injured persons in the Southeast region will receive care from a present integrated team of dedicated trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. Our chapter covers 7 states in the Southeast, so that includes Alabama, Arkansas, Georgia, Kentucky, Louisiana, and Mississippi and Tennessee. And again, we are a multi-professional organization. We're always looking to support our different team members, and we would like to encourage you to both join the chapter as well as a national SCCM, as this provides a great network for networking and educational opportunities. Here are our membership benefits. You can find more information on our website as well. Today, we have the pleasure of hosting Dr. Bookstaver, who's going to be talking to us about treating resistant gram-negative pathogens in the critically ill patients. And the following slide is how to obtain CE credit. We'll have the slide up at the end of the presentation as well, where you're able to scan the QR code and submit for CE. Please note that CE is restricted to, is a free benefit for all chapter members only. And again, if you're interested in joining the chapter, it is $45 per year for chapter membership. Please note that you have 2 weeks to submit for CE. So the deadline, the CE survey closes on March 28th. I would like to review some of the events recently. So in February, well, really January, we were able to meet back in person at the National Congress at SCCM, and it was a wonderful, wonderful event. It was great getting together with chapter members from all over the Southeast. We'd like to congratulate all our members and former leadership who were also bestowed the honor of FCCM. So with that, we'd like to thank you. We had a great turnout at our social, and we'd like to ask that you continue to attend our events, whether virtually or in person. And so in April, we're planning on having our first bite-sized lecture for the year, and the focus of this lecture is going to be on mentorship in the ICU. This will be held on April 19th virtually from 12 to 1 p.m. And we'll have different speakers who are well published in mentorship. It should be a very, very enlightening talk. Many of us take different roles of mentoring and teaching, and we invite you to join us. Be on the lookout for the invite that's going to come out via email. In May, we want to remind everyone that May is National Critical Care Awareness and Recognition Month, and this will be happening all the month of May. The chapter will be sending out emails to see if you're interested in hosting a Turn Your ICU Blue event at your hospital. This day is going to be Friday, May the 19th. Through the chapter, you're able to receive a stipend to actually treat your ICU teams with a small treat. So we look forward to hearing from you, and be on the lookout for emails. Other upcoming events will include our quarterly June education meeting. Again, this is a CE talk. Additionally, our following bite-sized lecture will be during the time frame of July and August. We're also looking to bring Twitter Critical Care Journal Club back. So if you follow us on Twitter, you'll be able to see announcements regarding that. And in the fall, so within the September-October time window, we are also looking forward to hosting our in-person Spike Out Sepsis event that is held in honor of sepsis survivors and sepsis victims, where we raise money that we share with the Sepsis Alliance to support efforts, research efforts, and prevention efforts for sepsis. So be on the lookout for information on that as well. This is an amateur sepsis volleyball tournament, and it's usually a lot of fun. You don't have to have a ton of volleyball skills, but if you just come with a great team and a great spirit, it's usually a great event. And we're lucky enough to bring it back just last year after COVID, and we're hoping to host it again this year. If you have any ideas for topics or speakers that you'd like to hear about or hear from, please email our programming chair, Doug Smith. You can also email us at the chapter email, communications@sccmse.org, and we will definitely take that into consideration as we meet to discuss planning for the chapter this year and next year. You can always support us on Amazon Smile, and you can also follow us on our social media outlets, so Twitter, Facebook, and Instagram, and you can find our lectures posted on YouTube. And with that, it is with great pleasure that I introduce our speaker today. So our speaker is Dr. Brandon Bookstaver, who is an associate professor and director of residency and fellowship training in the Department of Clinical Pharmacy and Outcome Sciences at the University of South Carolina in Columbia, South Carolina. He also serves as an infectious disease pharmacist at Prisma Health Richland. Following graduation from the University of South Carolina, he completed a PGY1 pharmacy practice residency and a PGY2 infectious disease residency at Wake Forest University Baptist Medical Center. Dr. Bookstaver thoroughly enjoys mentoring trainee research and is heavily involved in pharmacy residency training, including his roles as both an ID PGY2 residency program director at Prisma Health, as well as a PGY1 residency director at Tandem Health. He has over 150 peer-reviewed publications in the area of infectious diseases and teaching and learning. He has held numerous leadership positions within the American College of Clinical Pharmacy, the Society of Infectious Diseases Pharmacists, as well as the South Carolina Society of Health System Pharmacists and the Southeastern Pharmacy Residency Conference Executive Boards. Dr. Bookstaver is a fellow of the ACCP and Infectious Disease Society of America and is board certified in infectious disease pharmacy. Outside of work, he enjoys spending time with the wife and the children, running, traveling, and is interested in Gamecock athletics. We are very excited to have him talk to us today on a topic that is very relevant that we get to see within critical care all across the board now, with a focus on the management of resistant gram-negative pathogens. And with that, I would like to hand it over to Dr. Bookstaver.
Thank you, Rita. Really appreciate that. Very generous introduction there. Great to see some familiar names on here. So I just really appreciate the committee inviting me. And cool topic. This will be a fun topic. We have a couple of things we're going to talk about today, and hopefully get through each of these with some time to just discuss, ideas y'all have, thoughts you have. We're going to use a couple of examples to get through these objectives because we can't talk about everything, but some of this was sparked by the IDSA guidance documents that came out on resistant organisms in the last year or so. They were actually updated March of 22, kind of for a quote unquote final update or current final update. But we're going to go through, we're going to use two organisms as our examples, but the majority of time we're going to spend on multi-drug resistant or difficult to treat Pseudomonas. We're going to spend a little bit of time on AMP-C as well at the end. It's just a fun debate, and so I wanted to bring that up a little bit as well. And hopefully we'll dive in and give some thoughts about things that we do application-wise that may fit in here and things you can do in your own ICUs at your own institution. So thank you for being here. I have no relevant conflicts of interest or other disclosures. We'll come back to these definitions, but just to make sure everybody's on the same speed, multi-drug resistance, we're using that term quite a bit today. It isn't analogous to carbapenem resistance, although you will see a lot of numbers that look the same, because often when one is carbapenem resistant, at least for Pseudomonas, it's often multi-drug resistant, which is non-susceptibility to one agent in 3 or more classes. Extensive or extensively drug resistant is not technically endorsed as much anymore, but it does show up in some studies that we reference, and is used outside the United States still. So non-susceptibility to at least one agent in all but 2 or fewer classes. It's already hard to understand with that definition. It's almost like a double negative, but essentially it's a little bit more resistant than multi-drug resistant. And then we have difficult to treat resistance, and this is non-susceptibility to all of the following. So you're basically knocking out your anti-pseudomonal beta-lactams, including carbapenems, and your quinolones. So let's jump in with drug-resistant Pseudomonas, and we're going to talk about carbapenem-resistant and difficult to treat. And again, we're going to really focus on treatment decision-making here, and how we would weigh and compare maybe some of these treatment agents, and refer back to what this guidance document says. An obligatory slide just to say, why would we even pick or care about this one? Certainly multi-drug resistant Pseudomonas is a priority for both the CDC and the World Health Organization. Actually, World Health Organization considers carbapenem resistant Pseudomonas, I believe it's one of its 3 priority 1 or critical organisms for research and development of new drugs. A lot of treatment options out there, but some we consider, some we don't. We're going to talk about a number of these. We're going to cover every single one. We certainly don't have the time to do that, but we are going to touch on many of these from various angles. Their resistance profiles, if you will, where they add activity, where they don't, and get into where some of the clinical data, at least in the decision making for maybe some of our non-traditional anti-pseudomonal agents, and where we might prioritize one over the other. Well, let's jump right into something you kind of have to be aware of, even if you say, well, gosh, ID is not really my thing. I want to look up the CLSI document, on a daily basis. Definitely not promoting that type of thing, but I want to make sure that everyone's on the same page here when it comes to this being available. So CLSI, the Clinical Laboratory Standards Institute, their performance standards, which you are very likely very familiar with, but these performance standards are really at the crux of how we monitor and report susceptibilities for the drugs that we use. The M100 document, which is really both your performance standards, but it also has your breakpoints available, is a free document now. This has been made free in the last few years, and it was just updated a few days ago. And so I'm going to share with you a couple of important updates that are relative to Pseudomonas aeruginosa. One especially that I think is very important and intriguing, and was about a year or 2 in the making from some of the other subcommittees that work with this group and others. So if you'll orient quickly to this table, the first column is several of the drugs, so pip/tazo, and then the aminoglycosides. The middle column is the old breakpoints. And so I have a susceptible, intermediate, and resistant listed there. And then the update in the last column in March of 23. So pip/tazo, we'll take that one because that's a minor thing, but the intermediate category now only includes an MIC of 32, as opposed to 32 to 64, and now greater than or equal to 64 is resistant. That number keeps moving down in order to create even a greater buffer for patients that may have a harder time reaching target attainment. That was one of the original reasons that these MIC breakpoints came down significantly. But probably the more interesting and bigger change here is with the aminoglycosides. So I do want you to pay attention to this. So amikacin, we've long known in ID, and you certainly probably see this on a regular basis. These MICs seem ridiculously high with the old breakpoints. Like, really, 16 is susceptible? Am I going to really achieve anything there beyond a couple of hours when I give a wonker of a 15 to 20 milligram per kilogram dose, maybe even higher in some patients? And so what's happened is, all of those breakpoints for amikacin are no longer reported for other sources except for urinary isolates. So essentially, the decision at that committee level was, these are not really attainable. They're not appropriate for PK/PD, and so they're gone now, except for urine. Gentamicin, completely removed for Pseudomonas, okay, which makes a lot of sense. There's actually very few isolates that would make it susceptible in the revised breakpoints if you get all the way down to 1, which tobramycin now becomes the lone aminoglycoside here in this trio that would have less than or equal to 1 now as susceptible. So it's moved down from less than or equal to 4, and 2 is intermediate, then greater than or equal to 4 is resistant. So very, very important change here, and going to be very important to follow along for your individual institutions about how and when you update these. And we can talk later how you might start to apply these even without changes in your own lab. So in order to understand some of these other drugs that we might consider, we need to make sure we have a quick refresher on the mechanisms of resistance among Pseudomonads. And I'm only highlighting the 3 main ones against beta-lactams that we encounter in the United States. Okay, there are others, metallo-beta-lactamases. We're certainly not talking about quinolone or aminoglycoside resistance mechanisms here, but these 3 are very important. So number 1, there's a hyperproduction of AMP-C beta-lactamases, and these can occur really at high levels, very high levels, and we'll talk about which drugs are affected by these. Number 2 is porin channel changes. You might see that abbreviation OPRD. That's the outside membrane protein is what that stands for, outer membrane protein. And that OPRD is one of many porin channels, but it's one that's involved in antibiotic uptake. And so it allows, for example, carbapenems to pass through in order to get to the penicillin binding proteins. And so porin channel changes can result and have a direct impact, obviously, on some of these drugs. And then there's efflux systems. By the way, they're not just efflux pumps. They're a whole system involved here because you have a pump, but the pump also involves an outer protein membrane. So this OPR that we talked about before is a porin channel. It involves a porin channel as well, a different one. But these are really complex systems that can efflux out some of these beta-lactams as well. Now, when you think about how these are affected, I think this is a cool table, and this is just to orient you real fast. We've got the primary anti-pseudomonal beta-lactams first column, and then we've got the 3 primary mechanisms we just mentioned listed on the right. And what we tried to outline here is how these are affected, how these mechanisms of resistance that we encounter, how they impact each of these beta-lactams. So for example, with piperacillin, ceftazidime, or cefepime, none of those are affected by porin channels because they don't use that porin channel in order to access their site of action, whereas they're greatly impacted by hyperproduction of AMP-C and also efflux systems. Switch gears to imipenem and meropenem, and you have really a little bit different profile here, which is important. So, for example, porin loss will affect imipenem, typically resistant. Meropenem, it does affect it, but can maintain some susceptibility, so slightly different. The 2 biggest differences, though, between imipenem and meropenem come with the hyperproduction of AMP-C and the efflux system. So the hyperproduction of AMP-C does affect imipenem, and usually that's combined with porin loss, and you get full resistance with imipenem. But the hyperproduction of AMP-C doesn't seem to greatly impact meropenem, which is important, very important. And then the efflux system, on the flip side, doesn't seem to greatly impact imipenem, but certainly does meropenem. So you have porin loss and efflux system for meropenem. You have porin loss and hyperproduction of AMP-C for imipenem. So a little bit of participation, if you want to type in the chat, that'd be awesome here. I'm curious, and you can type this in over time. This will contribute to, I'm going to have a number of little polls that I throw up here. What percent of your Pseudomonas aeruginosa isolates, either in your ICU or at your institution, if you don't know individually, what percent of those are carbapenem resistant? You can give an exact number if you know. You can grab a antibiogram if you have it handy. Any of those things are fine. We are sitting at about 10 to 12%, depending on if you're going to look at our ICU, a little bit higher in our respiratory isolates as expected. Our numbers have greatly increased in a positive direction over the last 2 to 3 years. we somewhat joke, is that due to an Epic, a boost with switching to Epic and using their antibiogram system or not? But this is important and relevant. So if you don't know this answer at your institution, this is probably important going forward. So let's think about the frequency of these resistance mechanisms and how that might play into drug choice. So this is Sentry data, which is an excellent surveillance program that's been going since the late 90s. And this is looking at resistance phenotypes and what percent exist among bloodstream isolates and pneumonia in hospitalized patients. 15 to 20,000 isolates here, a total of 50,000. So for multi-drug resistant, this top row here, you're sitting about 25% of Pseudomonas isolates were multi-drug resistant. And of those 25%, 2/3 or so were extensively drug resistant, so knocking out even more drug classes. And not unsuspectingly, the multi-drug resistant and carbapenem non-susceptible really mirrors each other here. So about 24% meropenem resistance. Now, if you shift over to this figure just to take a look at this, this is actually from a poster from ID Week a few years ago. I haven't been able to find the publication of it. But this represents not only meropenem cross resistance, but meropenem resistance in the face of other resistance. So when you have carbapenem resistance, how often are there other beta-lactam resistance mechanisms? So the red here, which is the most frequent chunk, this is meropenem resistance plus 5 other beta-lactams or beta-lactamases. So very significant cross resistance exists when you're thinking about some of these complex organisms. This is a placeholder here as a quick plug for the Sentry surveillance program. You can access these data for free if you go to the Sentry jmilabs.com, and you can take a look at some of these data sets, and they're pretty fascinating to download and look through. Now, what do the guidelines say about treating these multi-drug resistant pseudomonads, okay, including carbapenem resistant? And each of these guidance, if you haven't looked at these before, they take a question and then they look and then they offer recommendation with a little bit of explanation below. Okay, so I underline a little bit here that I'm purposely interested for our discussion today is for infections caused by Pseudomonas isolates that are not susceptible to carbapenems but are susceptible to traditional beta-lactams, they do recommend the high-dose extended infusion of things like cefepime or piperacillin tazobactam. Now, remember back to our mechanisms of resistance, you can have that very commonly, and you probably know that, and you see that all the time because of that difference in porin channel effects on a carbapenem versus others. And porin channel effects are the most common with AMP-C resistance we see with Pseudomonas, and so this is important to note that this is part of those guideline recommendations. Now, this is nice and all, but if you look at all these resistant organisms and then you drill down to pip-tazo and cefepime, among these really resistant organisms, only 6% were susceptible to pip-tazo and 14% susceptible to cefepime. So yes, it's nice that that's an option and that's suggested, but at least nationally and internationally, maybe not at your institution, these are often co-resistant, and so we don't really even have that as a feasible option. So let's go further then. So what about some of these newer cephalosporin-based therapy? We're not going through drug profiles today, so there's a little bit of assumption that you know something about these drugs. I know this is a smart cohort on board here, so we're going to kind of move through the drugs a little bit and offer a little bit. So what about some of these new cephalosporin beta-lactamase inhibitor combos? So let's just compare briefly ceftolozane tazobactam, ceftazidime avibactam. So on one side, ceftolozane tazobactam, very important to note, ceftolozane alone is stable against those 3 primary mechanisms of resistance that we mentioned. So it's stable against hyperproduction of AMP-C, it's not affected by porin channel changes, and it's not affected by the efflux systems. And tazobactam does nothing to help it when it comes to Pseudomonas. So ceftolozane is your key drug there. It's awesome, okay? Lower MICs compared to ceftazidime avibactam across the board. We're going to show that data in just a second. Now, on the flip side, ceftazidime avibactam, there are some concerns of the elevated MICs, although you're going to see in a second, it still reaches susceptibility for many of these highly resistant organisms, somewhat comparable to ceftolozane tazobactam. But there are some concerns too, that deep in the deep pockets of the lungs, that there may be some difficulties getting target attainment in those lungs. And avibactam, in contrast to tazobactam, avibactam is definitely needed in order to restore that activity for ceftazidime against these resistant ones. And we just don't know a lot about the PK/PD profile of avibactam at this point. Now, when you take a fairly large cohort of clinical isolates from patients that were hospitalized with pneumonia in the U.S., you can see across the board here, whether it's carbapenem resistant, multi-drug resistant, or extensively drug resistant, they all sustain both of these drugs sustain good activity. Okay, minimum of 75% across the board. Okay, so susceptibility wise, you're probably going to have somewhat comparable numbers. However, when you dig down, MICs will very frequently, if not always, be lower with ceftolozane tazobactam, which is critical. So I'm going to take a deeper dive here into ceftolozane tazobactam, as I think, for me, that's certainly preferred for Pseudomonas over ceftazidime avibactam. So this is going to review just briefly a little bit of the clinical data that we have, which isn't a lot, but this was a matched cohort study, 6 studies around the Great Lakes area, Michigan primarily, of ceftolozane tazobactam compared to a backbone of aminoglycoside or polymyxin-based regimens for drug-resistant Pseudomonas. Okay, 70% of these patients in the ICU, most of them mechanically ventilated, and nearly half with severe sepsis, septic shock, and VAP. So a very sick cohort. Now, when you look at some of the outcomes here, okay, clinical cure, which was defined at the end of treatment here, 81% in the ceftolozane tazobactam group compared to 61% in the aminoglycoside polymyxin group. Swap those numbers. I really should have put them in better order here. The AKI results also favorable to ceftolozane tazobactam, but not unexpected. I mean, if we're using polymyxin aminoglycoside-based regimens aggressively, especially polymyxin ones, we're going to encounter quite a bit of AKI, and a third of patients developing AKI in that polymyxin aminoglycoside-based regimens. Now, immediately you may say, well, that is not something we use at all, and that's not a great comparator. Maybe not, but that is what we had. You know, before a lot of these treatments came out, that's what we were using. And that's where the need came, because the toxicity was so great. And so the clinical outcomes strongly favor ceftolozane tazobactam in this regard. And mortality was not significantly different. It was 5% numerically lower in the ceftolozane tazobactam group, so nothing alarming, but nothing significantly different on the mortality side. This is a real world experience here, just no comparator group, but just a little more data to add to the conversation. 205 patients, half of them in the ICU. Real world experience of ceftolozane tazobactam versus multi-drug resistant Pseudomonas. Fairly sick population. And important to note here, on average, the drug was initiated on day 9 of therapy. So this is real world, right? We start with a carbapenem, or we start with a combo therapy or piptazocefepime. We finally get data and we escalate therapy later. And in this case, clinical success was 74%, mortality 19%. Again, no comparator, but maybe we would say comparable numbers to historical literature. But really interesting is, if you started ceftolozane tazobactam within 4 days of culture collection, it was significantly associated with the likelihood of survival. So something that we may talk about later. Now, very quickly, a couple of dosing considerations I want to point out that make sure that we hit a couple of what I think can't miss points here. Number one is the manufacturer labeling, when we're talking about these kind of infections for these types of bugs, is 3 grams IV every 8 hours over 1 hour. And that's even the manufacturer's labeling now. We have been using a continuous infusion at our institution. We give 6 grams over 24 hours as opposed to 9 grams for some of these infections. We first used it in cystic fibrosis. We've now extended this to a number of our patients. We see a lot of these infections in our LVAD population. Some of them are in the ICU, some not. It maintains, we've done therapeutic drug monitoring on a fairly decent cohort of these folks, and it maintains concentrations well above 4 times the MIC of 4 mics per mil, the break point. And so we use it inpatient and as a transitions of care. Now, another drug we might consider, okay, cefiderocol. Let's take a look at its activity. This is a siderophore cephalosporin, really neat. Does bind to PBPs, but it also has this iron transport mechanism, the Trojan horse mechanism, if you will, allowing it to get across the membrane. So pretty cool. But where does this fit in from an activity standpoint? Cefiderocol is not affected by any of those three primary mechanisms of resistance that we've mentioned so often. This is why you're seeing the numbers here that you see. All the way down the board, imipenem, relibactam resistant, 100% susceptible. Ceftolozane, tazobactam resistant, 89, 88, 89%. Cazavi, 91%. Well, how does that compare to some of the other drugs? Well, in the extensively drug resistant, the best comparator is 73% here, and pretty similar across the board for those other three agents, okay? For ME-Reli resistant, really, you don't have hardly any other options, 21% and 35%. What about for ceftolozane tazobactam resistant? ME-Reli at 43%, your other best option. So very similar down the road. You can see very few. Interestingly enough, too, there were 27 isolates that were pan-resistant to the beta-lactam, beta-lactamase inhibitor combos. And very cool, 100% of those were susceptible to cefiderocol. So it's got the activity. Okay, this is Century data as well. It's got the activity. What about the clinical data? So the credible CR study, some of you are probably very familiar with this study. This was an open label randomized controlled trial that was cefiderocol versus best available therapy for very serious carbapenem resistant infections. Pneumonias, sepsis, bloodstream infections. There was a cohort who had complicated urinary tract infections as well, but they had to meet some sepsis criteria. They reported clinical cure at a test of cure. They also reported mortality all the way through 28 days at the end of therapy. They were enrolled 2-to-1. Cefiderocol had roughly 100 patients, and the best available therapy had 50. Typically, they were on combo therapy with about 60% of these colistin-based. So looking at one particular endpoint, we're going to pick out a couple, but looking at clinical cure. So I just summarized nosocomial pneumonia, bloodstream infections, and then overall, okay? So you can look pretty comparable here, okay? 60%, 63% for nosocomial pneumonia, a little bit higher in the bloodstream infections, and overall 66 and 58%. If you pick out just Pseudomonas aeruginosa infections, fairly comparable, 58% for cefiderocol, 50% for best available therapy. The numbers are important here. They're small, so 5 and 6% changes, even 10% changes can occur with one or two outcomes either way. Now, this is where it gets interesting, though, and you've probably heard of this. If you haven't, this will hopefully be one of your take-home things today. This is what was unexpected a little bit. So you had some at least comparable clinical endpoints there, but look at mortality. Overall mortality, shift all the way to the right to start with. In the cefiderocol arm, 34% mortality at the end of the study versus 18% in the best available therapy. And those numbers were consistent with pneumonia and bloodstream infections. Now, when you look at it by organism, the biggest difference was in Acinetobacter for sure. Pseudomonas still a difference there, but I do caution you on the numbers. I mean, you take one away from cefiderocol and add one to the best available therapy, and you're getting pretty darn close to the same numbers. Club Pneumo was the same, but again, small numbers. So this was intriguing. This was intriguing. Now, we're going to circle back to this in a second. What about another study, the Apex MP study? This was actually a randomized controlled trial with larger numbers. This compared cefiderocol versus high-dose extended infusion meropenem for HAP-VAP. This was not carbapenem-resistant organisms, but it's important to look at to try to put those other outcomes in perspective. So these clinical cure overall, and then if you break it down by HAP or VAP or organisms, pretty consistent across the board. Okay, no significant difference here. They all fell within the expected confidence intervals, and no major difference. You could say HAP was numerically 12% less, but again, not huge numbers to go by, but nothing, no signal like it was in the highly resistant organisms. So what did this mean? What did this matter? Well, if you look at the cefiderocol manufacturer's labeling, there's a warning. The number one warning and precaution in the package insert is increase in all-cause mortality in patients with carbapenem-resistant gram-negative bacterial infections, and then it refers you to that study. So that's significant. as pharmacists have more responsibilities and are doing more and more things in patient care, I think pharmacists also start to assume a little more liability as well. And that might be something our profession has not thought a whole lot about. Um, as someone who sometimes on occasion serves in those regards, for whether it's an expert witness or a case review, these are things that come up interestingly quite a bit. So just a consideration. Now, a couple other notes from the manufacturer's label that are important in my regard, just to make sure we don't miss those today. It is approved at 2 grams IBQ8 over a 3-hour infusion. Okay, so it already is approved at an extended infusion. So all of these data are based on an extended infusion. So if you were to change that, which I'm not saying you would, but if it were accidentally given incorrectly, certainly none of these would apply. And there's also dose modifications that happen for these augmented renal clearers. And so it actually goes to Q6 hours when your clearance is over 120 mils per minute. Now, what about one other one? Imipenem relebactam. Okay, so relebactam is a non-beta-lactam beta-lactamase inhibitor, kind of novel in that avibactam grouping. This is called the SMART data set, but a large cohort of Pseudomonas aeruginosa isolates. And if you look most importantly at that middle row, imipenem non-susceptible. So how well does relebactam help restoring activity? So 0% among almost 4,000 isolates up to 70%. So that to me is excellent restoration. Now, why does that happen? Why does that happen? Well, if you remember, the relebactam as a beta-lactamase inhibitor, that one actually has activity against AMP-C. If you remember from a few slides ago, AMP-C is one of those primary mechanisms for imipenem resistance. And so relebactam is restoring that activity and certainly lowering the MIC significantly. In this cohort of imipenem non-susceptible isolates, the arrow on the right, this is an MIC of 16, which was the mode MIC distribution of imipenem, and that was lowered all the way down to 1 with the addition of relebactam. And these are the worst of the worst isolates here. So very significant, very significant. This is that reminder. I'm going to skip it for time, but that was this reminder of the AMP-C hyperproduction. Now, what about clinical data? There's just not a lot, unfortunately. So one of the best ones we have is for this cohort of organisms is called the Restore IMI-1. And this was a randomized study looking at IMI-RELI compared to colistin plus imipenem. So kind of still a best available therapy, if you will, looking at these severely ill gram-negative infections, typically again a pneumonia and very complicated intra-abdominal. Overall clinical response very comparable between the two. Mortality comparable. I'm going to say comparable, even though numerically it's a lot lower, but you're talking 10 isolates versus 21. But as expected, the nephrotoxicity significantly lower. Okay, most of these isolates were Pseudomonas aeruginosa. That's about all we have for the highly resistant kind. Okay, now there is a larger study, the Restore IMI-2, which was IMI-RELI versus Pip/Tazo for HAP/VAP, and the IMI-RELI met all the non-inferiority qualifications and endpoints for clinical cure and mortality. But to me, it's not going to replace Pip/Tazo as an entry drug, so I couldn't conclude a whole lot based on it. But at least it does give you a little more data, maybe a little more comfort if that's what you're looking for. Now, when you take all these in totality, we have this idea of very resistant bugs. And so there's this, what proportion of your isolates are considered difficult to treat by definition in your organization? Okay, I'm very curious how many of you know this offhand. Remember, difficult to treat is you're resistant to all the anti-pseudomonal beta-lactams, including carbapenems. You're resistant to the quinolones. You're resistant to the colistin. I mean, you're real resistant here. You don't have a whole lot to go off of. Okay, you still could have colistin, excuse me, but you don't have a whole lot to go off of. So very curious. We probably won't have time today. I have the slides not included, but I do have them separate. We actually did a study on this in the Southeast in our Surge 45 group recently, looking at the proportion of Pseudomonas isolates that are difficult to treat and compared that to how hospitals were using these drugs. because when we often report how often we use some of these newer agents, some places are either holding back using them or they feel like they're overusing them. And so instead of just reporting days of therapy like a lot of stewardship programs do, we actually proposed putting another denominator in there and looking at your resistance rates. So if hospital A had a lot of difficult to treat Pseudomonas or a lot of carbapenem resistant Pseudomonas, they should be using more ceftolozane tazobactam or imurelli compared to another hospital that just feels like they have sicker patients or feels like they have an older oncology population. So we proposed that, and it's very interesting. So if we have time, we'll talk about it at the end. So what does the IDSA panel say for these difficult to treat Pseudomonads? Well, they recommend ceftolozane tazobactam, ceftaz-avi, or imurelli as monotherapy when it's an invasive infection. I'm not really worried about cystitis here. So when it's an invasive infection, they recommend one of those 3 agents. Now, my summary thoughts, okay? I'm still comfortable with cefepime pip-tazo for carbapenem resistance, but I would certainly maximize PK/PD. So you obviously have to be susceptible, and you really need to maximize using some type of extended infusion. Now, if you're on the borderline of the breakpoint, say 8 for cefepime or 16 for pip-tazo, I'm probably going this route of one of these other preferred agents here, okay? Is there a role for beta-lactam TDM in these patients that we're talking about who need maybe some aggressive dosing and we're not sure how to match it? Augmented renal clears, obesity, maybe volatile renal function. We can talk about that in Q&A. We're doing some of that now, so we can talk about it. For me, ceftolozane tazobactam is my go-to based on the available data. Not only does it have good susceptibility profile, the ceftolozane is probably pound for pound the most active drug. And we have some data and experience with it, even more so than maybe some others. And I still give pauses to cefiderocol, although I kind of put that last line because I think it does have some value, especially for polymicrobial infections. This is very important, so don't miss this. Susceptibility testing cannot be underestimated here because there's so many mixed resistance mechanisms with Pseudomonas. It piles on the multiple resistance. So we think we can predict something, but we don't really know exactly what's going on unless your lab has molecular testing capability. So please make sure you're doing that. And then guidelines would argue against combo therapy, although we don't have time to talk about it today, unless there's no first-line options available that are listed there. I do want you to think about this question. We'll talk about it during the Q&A a little bit more. But when you're in the ICU and you recommend an empirical antibiotic regimen, how often do you ask yourself this, what is the likelihood that we're going to cover the most likely pathogens in this patient with the regimen I just recommended or that we just started, even if you weren't the one to recommend it? So think about it another way. How right do you want to be? Well, don't say 100%, okay? How practically speaking, what is your minimum acceptable number when it comes to your empirical antibiotic choice? I'd really appreciate if you type these in, if you're not even typing anything else in, because I'd love to chat about these in the Q&A. But in a patient with suspected gram-negative HAP-VAP on vasopressors, and you recommend meropenem, or you recommend meropenem and give them a dose of Tobra, or you recommend pip-tazo, or ceftolozane tazobactam, imurelli, how right do you feel you need to be? Okay, I think it's kind of fascinating. Okay, so the reason I brought this up, we actually surveyed folks a few years ago looking, and we gave them several different clinical scenarios that had different predicted mortality, where there was evidence to say this person has a predicted mortality of X. And in the scenario we had of a critically ill patient with a fairly high predicted mortality who was bacteremic, the mean acceptable susceptibility percent that we had was about 90% among ID and critical care practitioners. Most of them were pharmacists practicing who were surveyed. So we can come back to that. Pretty fascinating. Okay, other thing I want to cover fairly briefly in about 8 to 10 minutes is the AMP-C producing Enterobacterialis, okay? The reason I wanted to bring this up is it's not nearly as complex as multi-drug resistant Pseudomonas, But I wanted to mention it because, one, I'm curious about how y'all practice in this, and two, it's fairly debatable still at our institution because there's a lot of knowledge gaps, but there's also a lot of unknown things that allow for that debate. So AMP-C beta-lactamases, your quick crash course, they're Ambler class C enzymes. There's three main categories. The one we care about today's discussion is inducible resistance among organisms like Enterobacter cloacae and Citrobacter freundii. Okay, this inducible resistance, what does that mean? Well, there's an AMP-R protein that actually regulates, it represses, so it doesn't allow for AMP-C production at normal conditions. The problem is if you induce it or tease it with something, that it can actually lead to the production of some of these degradation cell membrane products, and they kind of smash into the AMP-R protein and they change its figuration, and that causes it to lose its function. And when that happens, you de-repress, so then you ramp up the AMP-C production. Well, now you've got a producer of AMP-C. So why is that concerning? At the practical level, it's the ceftriaxone susceptible organism first, and then a month later, 2 weeks later, 3 months later, whatever it may be, you repeat it, and now you've induced AMP-C production in that particular isolate, and now it's third generation cephalosporin resistant. So there's a number of substrates and inducers out there. The third generation cephalosporin, ceftriaxone and ceftazine, are actually inducers. Okay. The poor substrates, which are important, imipenem, cefepime, and meropenem, the reason why those are important is they're not really affected by this AMP-C production for the Enterobacterialis, okay? That's different than the hyperproducers we were talking about with Pseudomonas, okay? So that's important to think about when we think about it as induction. We're worried about here, if I give ceftriaxone or ceftazine as a third generation cephalosporin, am I gonna lose it down the road? Well, many of you are probably familiar with the space and spice. Maybe you picked up on that on those little pictures earlier. These are things that have been taught for decades. This is how I learned it as a student, literally a long time ago. But the space and the spice. So Serratia, Pseudomonas aeruginosa, Acidobacter, or indole-positive organisms like indole-positive Proteus, Citrobacter, Enterobacter species. And that gives you this space or spice mnemonic. Now, pros, it's technically accurate, okay, for the ability to produce AMP-C, and it's been historically taught. So there's been a lot of learners who are now teachers who have been teaching it. So that's a lot of decades of people who learned it one way. I think we all know when something's been learned one way, it's very hard to unteach it, very difficult, okay? It's also easy to recall, space and spice, very easy, okay? The cons, it's rarely accompanied by an explanation. It's just space and spice, and some people call it MySpace, because they want to throw in some others. Yersinia, may move the Morganella to the M. Those are all acceptable. But the problem is it doesn't account for the variability in producing AMP-C among these organisms. It just kind of all considers them the same and really talks about nothing about clinical relevance. So let's mention that for a second. This is the way I teach it, is the RPMs on the side. So I'll show you that in a second. But when you think about variability for these, the three main organisms that are thought to be the highest likely producers of AMP-C, inducible AMP-C now, are Enterobacter cloacae, formerly Enterobacter aerogenes, now Klebsiella aerogenes. There was a name change in case you missed that, and Citrobacter freundii. Now, Enterobacter cloacae is like the RPM there of revving it up to 7 or 8, okay? Citrobacter, Klebsiella aerogenes, probably in that closer to 4 to 6 range. And then the other things like Serratia, Proteus, Providentia, those are down in the 0 to 1 range, okay? That's the difference when you think about inducible AMP-C. In these bugs, it's been documented up to 30 or 40% of infections can have inducible AMP-C during treatment with a third generation cephalosporin, for example. So that's a big deal. Now, how does this compare? Well, it's about 50 to 150-fold higher than Providentia and Serratia marcescens, and about 600-fold higher than Morganella. So it's really hard to put them all in the same category, and the new guidelines don't do that. So a new proposed mnemonic for the moderate to high risk for inducible AMP-C is this concept of heck yes, okay? If you want to ignore the H and the Y for Yersinia and Hafnia, that's fine because we don't really know a whole lot about the inducible AMP-C of those two organisms. But the ECK in the middle are your real critical organisms to remember. So two big questions to quickly pose and just throw them out there. These are probably things that come up in your day-to-day. So we'll look at what the guidelines say about this. Can we or when can we use ceftriaxone as a definitive therapy for these infections? And can we or should we use piptazo as a definitive therapy for these infections? So we'll start with the ceftriaxone here. This is a study we did a number of years ago in our SURS 45 group, trying to answer, well, not trying to answer it definitively, but give some data behind this. These are 381 patients from 18 hospitals in the Southeast, and we compared definitive third-generation cephalosporin, primarily ceftriaxone, versus non-third generation cephalosporin definitive therapy. So this could have been quinolones or carbapenems or even piptazo for bacteremia due to Enterobacter, Serratia, or Citrobacter. Those three were included. About 40% ICU, about half and half hospital acquired versus community onset, and about 20% were urinary source and 20% were a central venous catheter source. So those 40%, a lower inoculum of infection for sure. And what we found for overall treatment failure, which that was a composite endpoint for us that had to do with death, reinfection, or clinical failure. And the reinfection was up to 90 days, and the death and clinical failure were at 30 days. So what we found was a comparable overall treatment failure. About a third of the patients getting ceftriaxone compared to about 30% getting non-third generation cephalosporin definitive therapy. Mortality very similar. Reinfection numerically slightly higher in the definitive group. And really with regression models, we didn't show really much difference, okay? There's been other observational studies a little bit smaller than these that have shown similar results, but you still can't ignore the data that there are breakthrough data showing a high proportion, especially for Enterobacter, Citrobacter, and now Klebsiella aerogenes, okay? But these are clinical data to help frame the discussion at least a little bit, okay? Well, the IDSA guidance, I should say, they really say don't do this for invasive infections for the high risk AMP-C producers, Enterobacter, Klebsiella, and Citrobacter, okay? But it may be a reasonable option for cystitis, stated right there in the guidance, okay? Now, why else is that mentioned, and why else do they come to that conclusion, okay? Because I gave you kind of a general number of the bad outcomes because of the inducibility up to 30–40%, and that's bad enough. We don't even have to go into too much detail there. And then maybe some of the observational data that's net positive or net neutral there. But there's a couple other things. One, we don't really identify AMP-C itself in a clinical lab. Number two, it's very hard at this point to ever get rigorous studies to tell us what's going to happen. You know, it's very difficult. And if you go back in time, there's been changes to the breakpoints, and now it's going to make it very difficult to carry data forward. So it's kind of comparing apples to oranges. So that's going to make it very hard to really probably ever study that definitively. And so I think we kind of have to accept the fact now that is there a difference between these high and moderate producers and the low producers, okay? So for me, one, I always remind myself and our providers, inducible resistance needs two things to occur. You have to have some inoculum, so you have to have bacterial burden, and you need some time for exposure. It doesn't just happen magically, okay? Now, unfortunately, we don't know exactly what level of inoculum and for how long in humans that exposure. I've heard 7 to 9 days, blah, 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 but we don't really know, okay? And so locally, we consider ceftriaxone for those non-high risk AMP-C producers like Serratia after we have source control of high inoculum infections. And I'm not really going down the cystitis. If we had to use it, yes, but we're probably using something else, to be honest with you, not even a third generation IV cephalosporin. So, but it's important here that we do differentiate the non-high risk AMP-C producers like Serratia from some of those others. So if ceftriaxone is out, where does cefepime fit? Well, according to this guidance document, cefepime is suggested as the treatment of choice for those high-risk AMP-C producers, okay? So where ceftriaxone doesn't fit, slide cefepime in right now. That's when the cefepime MIC is less than or equal to 2, okay? Less than or equal to 2. So that's a preferred option. If it's greater than that, so if it's 4 mics or 8 mics per mil, the break point, then carbapenems are recommended, okay, because ESBL co-production may be present, and I'll mention that in just a second, okay. When you look at observational studies, there's really been comparable outcomes between cefepime and carbapenem. That's about the best we have right now between those two. What is so magical about this 4 mics per mil for determining cefepime therapy or not? Well, when you're at 4 or 8 mics per mil, there's a high correlation between ESBL producers, meaning, for example, Enterobacter species that have a cefepime MIC of 4 or 8 are highly likely to also co-produce ESBL. And so we now know from a Reno trial that carbapenems should be the drug of choice there. That's why carbapenems are recommended in this particular document. Now, wait, we didn't talk about PIP/TAZA, so we'll do that real fast. A fairly big meta-analysis of 8 observational studies didn't show a statistical difference in mortality between PIP/TAZA and comparators, mostly carbapenems, for the treatment of bacteremia due to AMP-C producers. But if you took 2 studies that were actually decently well done and controlled, the 30-day mortality in both of those combined, PIP/TAZA was 25.4%, carbapenems 9.3%. So numerically, there's some hints there that it may be concerning. There was a Marino 2 trial done. If you weren't aware of this, it was only the pilot, so very small numbers here, but that was PIP/TAZA versus meropenem for AMP-C producers. So we had PIP/TAZA versus Mero for ESBL in Marino 1. This is AMP-C producers for bloodstream infections. Numbers are small, less than 40, okay? And they're just odd. So 30-day mortality, none in PIP/TAZA, 6% in Merom, but the clinical failure rate was 21 versus 12 in PIP/TAZA. The microbiology failure was higher in PIP/TAZA, 0 in meropenem, but the relapse was very low in PIP/TAZA and 9% meropenem. I think all a subject of small numbers, and so you just can't conclude very much. But with the totality of that, the guidelines say it's not really suggested. You've got other options and other things that are better. And one of those part of this may be due to the fact that tazobactam is really less effective too than other newer beta-lactamase inhibitors against AMP-C. So you're also giving a drug that we know, at least from a beta-lactamase inhibitor standpoint, is probably not as good. Now, I do want to mention these 2 things, and then I'm going to kind of stop. So one thing to consider: does your institution have an automatic testing algorithm for these multi-drug resistant or difficult to treat gram-negatives? Meaning, does something just prompt the microlab to do more than what you would do in an automated situation or what you would do in a non-multi-drug resistant situation? Curious your opinion there. And then, who at your institution has the ability to request special microsusceptibility testing? Okay. Is it restricted to ID or stewardship or both? Can anyone do it? Is it restricted to ID, stewardship, and critical care? You don't know if there's even one of these. You don't talk to the microlab. I'm just very curious. And so the reason I bring that up is a couple of practical applications based on all this conversation. So number one, I think it's very important to partner with microbiology to have an automatic testing cascade. So for example, what we do, we have an algorithm that our microlab automatically follows. So if we have a carbapenem resistant Pseudomonas, our microlab knows exactly which additional tests to do, so that we're not waiting to request it 2, 3, 4, 5 days down the road when someone thinks about it, and vice versa. It's not done incorrectly when it's not needed, and someone's requesting it when it doesn't need. So that's important for us. So that's automatic. So we actually get them back much faster to help. And remember, I mentioned that testing is very important. I think it's important for y'all in critical care to partner with your ID and stewardship to determine the proportions that you have of these resistant organisms, so that you know when you're going into your to rounds, when you're investigating these patients from an empirical standpoint, where do these decisions need to happen? Do they need to happen early? Can they happen later? Those are important. We leverage a lot of precision medicine in our institution. We use resistance prediction tools that are homegrown. One we use is an anti-pseudomonal beta-lactam resistance tool, where we calculate a risk that someone may be resistant and have either difficult to treat or multi-drug resistant. And we do select patients do get beta-lactam TDM. Some of these may be these very patients. So my last slide, and then we'll kind of open it up and I'll check out the chat too. But please keep abreast to changes in breakpoints, like the tobramycin being lowered for Pseudomonas aeruginosa, the amikacin basically going away, except for urine, the gent going away completely. Can you go ahead and implement these anyway? You know, can you still apply them in your day-to-day? I think that's important conversations to have at your institutions. The primary mechanisms of resistance, those three main ones that we talked about, ceftolozane tazobactam, I think, is an excellent choice for these difficult to treat isolates, maybe in some cases for the carbapenem resistant isolates because of the higher MICs you might encounter with piptazo or cefepime if you can't dose optimize those. I think in the frame of mind with AMP-C producers, I think you've got to separate the high risk versus the low risk. Cefepime is certainly a preferred option for those unless it has a higher MIC. And perhaps ceftriaxone belongs a little bit less outside the ICU. We sometimes use it as mop-up therapy late when everything's been controlled. And we still use it in those low-risk AMP-C producers, but that's after source control has been obtained. And then carbapenems would be the drug of choice if the MIC goes up. And then consider when you can apply your local data to help support your patients. You know, maybe these are local research opportunities. A lot of what we do are interdisciplinary research at our institution. It really helps us enhance our precision medicine approach as we get a little bit more of our patient level data, especially when we're having to do things empirically. And as y'all know, decisions you make before you get information back could make or break it for the patient. So you know better than anybody the meaningfulness of timely therapy that's appropriate. So with that, I will be quiet, and I'll that code there is for the CE stuff, Rita, I believe. And so if there's any questions, I'm happy to take questions or chat about things. If we're totally out of time, that's fine too. And you can certainly share my email or any information you wish to get in touch. I'm more than happy to chat with folks about how they're operating things.
Thank you so much. This was an excellent talk. It was very, very practical, so we really appreciate you. I'm going to ask our audience, if you have questions, please go ahead and type them in the chat, and we'll certainly read them out loud. I jotted down a few things that I wrote down, and as questions come in, we'll entertain them. But I wanted to ask you, I know you mentioned doing continuous infusion, ceftolozane tazobactam. So can you shed a little bit of light regarding the TDM that you guys have done, and in terms of data, et cetera, how you've compared that to the extended infusion? And then also what does that mean at the bedside? Have y'all done any compatibility testing, or does that hold up a line the entire time?
Great questions. I'll tackle a couple of those as I can. The continuous infusion, we put 6 grams in 500 cc's of normal saline, and we run it over 24 hours. The original time we did it, we actually did over 12 hours because we were lacking, I think, a little bit of stability data, but that has since been confirmed. We actually worked with one of our home infusion companies who is very interested in offering this, we don't have full stability data, or excuse me, compatibility data. So that still becomes a problem a little bit. Stability, we're fine, but compatibility data does still become an issue. So we do have to tackle those one-on-one. Thankfully, we don't use this a lot, so it can still be kind of handled on a one-on-one basis. A couple of things it's done for us, though. We only use 6 grams instead of 9, so financially it's valuable from that standpoint for a total daily dose. But 2, we confirmed it in really who should be some of the most hyper clears, augmented clears out there: cystic fibrosis patients, some of our trauma patients that we've used it in. We use it quite a bit in our elderly LVAD populations. That's a little bit of an outlier. They don't really clear, obviously, but consistently across the board, they have had great levels. So we don't monitor it in everybody. And in fact, a lot of the patients who get it have had it before because they just are colonized and they come back or reinfected 6 months later, a year later. We partnered with Dave Nicolau's lab in Hartford, and we ran them as one-offs for a while. okay? And that's why we don't do it as much now. We needed confirmation locally that we were not harming someone and we were doing the right thing. We've had extremely positive outcomes from doing it. And originally we were going to use it as only a transitions of care, but now we've used it some in our inpatient folks. If there's a line issue, we just stick with the 3 grams Q8 and don't worry about it. I will mention the TDM for beta-lactams. We also have partnered with Atlantic Diagnostics. Actually, our fellow Vivian Tsai and Julie Justa, one of my colleagues, really started this TDM model that we have that we share between our ICU pharmacist and our ID pharmacist. And one-off request, we can get about 24 to 36 hour turnaround to get data back. So if it's a obese augmented renal clear that you're worried about a cefepime level because the MIC is 4 or 8, then you have that data back. Or you're trying to push the dose of some of these drugs and all the conversations about cefepime neurotoxicity, and now you're trying to push the dose and you know those kind of things, and it just gives you a little peace of mind. Or you're settling a debate on rounds, I don't know what it may be, but it's been helpful. We don't use it a lot, so it's not on every patient or anything like that. It truly is one-offs for people that could benefit. But we've had really good results, and they've been a great partner, to be honest with you, and we've been doing it for a while now.
Thank you so much for sharing your clinical experience with them. I see we have a question in the chat, and it reads, with the changes in aminoglycoside MICs, is there still a role for double coverage for gram negatives in septic shock in patients with risk factors for resistance?
Good question. You know, the tobramycin dosing or breakpoints is based on a 7 mg per kg every 24-hour regimen. So when you consider the breakpoints, the new guidelines are doing a good job putting it into perspective of the pharmacokinetics and dynamics, so that that doesn't apply if you're only given 4 mg per kg. It technically was based on 7 mg per kg every 24 hours. So certainly in our guidelines locally, when we predict a anti-pseudomonal beta-lactam resistance, we certainly may give them a dose of tobramycin. I think what it does is it puts it in perspective even more that you need to be aggressive with the dosing. The extended interval dosing is important to maximize pharmacodynamics, I think. It also puts in perspective that maybe we're not getting as much bang for our buck as we once thought because of the dynamics. Amikacin may go by the wayside. I mean, sad to say, I mean, when I trained at Wake Forest, that was a long time ago, but it was Zosyn and amikacin for every HAP VAP. That was it, everybody. We even developed our own 21 mg per kg once daily extended interval dosing based on kind of an extrapolated algorithm, and that's basically gone. I think there'll still be some inhaled use. I think there'll still be some IV use for sure, but at least for Pseudomonas, you're starting to see those fade a little bit. And I think it's also then going to encourage, we really probably are going to have to leverage some of these new agents when we really get into a bind with drug resistance. But yeah, it's going to be fascinating. There's already data out showing how much it's going to impact. Some people have already applied that based on the committee's recommendations from last year, and it's a drastic change for some of them. Gentamicin went away. I think I mentioned that at the beginning and then at the end again. But if you took the same breakpoint changes and you moved gent down to less than or equal to 1, only about 20% of isolates in Pseudomonas would be less than or equal to 1. So that was the reason it went away, because there would be nothing susceptible anyway.
Thank you very, very much for elaborating on that. We're still taking questions, so if anyone would like to put in anything in the chat, that would be wonderful. Do you use extended interval dosing for aminoglycosides in patients on CRT?
Good question. I think our critical care pharmacists, we give them a lot of liberty when it comes to, I mean, they're really the experts on that. We give them a lot of liberty on that. There's a difference in practice, I think, even amongst our critical care pharmacists, depending on the unit that they work in, whether they're neurosurge or CVICU or MICU. So there is some variability there. I think one of the issues that I would consider is the consistency of CRRT, if it's going to be interrupted versus it's going to be very acute short term, and then we're transitioning back to intermittent or vice versa. So I think that's one of the considerations. Again, extended interval probably has more benefit than not, but it's also not the end all be all, and it's not going to be your primary drug either. And so I think that's important to remember. I don't think you're wrong in either regard. I wouldn't want to label either of those approaches as wrong. I think as long as you're doing your due diligence from TDM, that you can manage it.
Great. Brandon, what are your thoughts on the use of quinolones for AMC producers, the high-risk AMC producers, if you're trying to spare the cefepime for in some of these long-stay ICU patients where you're suspecting they're going to have risk factors for Pseudomonas and you're trying to reserve the cefepime for them?
Yeah, good question. You know, Enterobacter is not like E. coli when it comes to quinolone resistance. I mean, Enterobacter is highly susceptible to quinolones. I mean, you might not have given that a whole lot of thought in the antibiogram lately, but go look at your antibiogram, and E. cloacae is going to be pretty susceptible. It should be highly more susceptible at your institution than E. coli for quinolones. So that certainly is an option. We primarily use them as transition drugs, you know, IV to oral. We do use them probably more than most places in the country. We're very, we joke and people poke fun of us a little bit for being pro quinolone, but we use it a lot to transition people to oral drugs, a whole lot, especially in gram-negative bacteremia, and we've been doing it consistently for a long time. You know, numbers wise, there's not going to be a whole lot of E. cloacae that's causing these to allow that to happen. I think while we don't have the data, I certainly don't think that Cipro dose optimized, maybe it's 400 Q8 in a critically ill patient, you know, I don't think that would be inferior. I think if you went with people's gut, that they're going to say, I prefer beta-lactam for my really sick patient. And so I'm going to be in the category, and this is opinion-based medicine mostly, but I'm going to be in the category of I'm going with a beta-lactam in a critically ill patient, but I'm very apt to transition them to a quinolone when oral therapy is appropriate. And maybe that still reserves a little bit because I might not need them on an IV cefepime or a carbapenem in some situations for a long time. Maybe I can streamline them to a quinolone earlier than expected. And while that may or may not happen in y'all's environment as much, it still can be encouraged on maybe a transition of care, you know, a handoff to the floor and things like that, where there's a reevaluation, because so often the plan gets put in place, you know, for 10, 14 days or whatever it may be, and no one reevaluates the cefepime on day 6 when they got out of the MICU or STICU, and now they're able to maybe go to a quinolone. So.
Thank you. That's very, very helpful. A lot of times we're not just treating one set of infection, it's multiple, and you kind of have to plan ahead for what to use when.
You do. We actually joke too that when we have the debate on the AMC stuff, we just say, well, that's fine. Just give them Cipro and we can stop debating about it because the Cipro won't be affected anyway. And so that's sometimes how rounds ends when we're there.
We're still taking questions, so if anyone has any questions, please feel free to type them in the chat. I had a question for you regarding imipenem relebactam. In practice, at least at our institution, we've definitely picked up more in terms of our ceftolozane tazobactam, avibactam, and cefiderocol use. What would be the role of therapy of imipenem relebactam if you have access to some of these other agents?
Good question. I think it's a tiered approach. So I think that for me, either a carbapenem-resistant Pseudomonas that's got really high MIC, cefepime and zosyn, or one that's going to be resistant to those two, which is in our institution, it's pretty common that they're not susceptible or they're right on the borderline. Then we're going usually ceftolozane tazobactam first. But we confirm everything with MICs. We do have, as I mentioned, we have a lot of patients who this could be their second or third time coming back on ceftolozane tazobactam. And unfortunately, and I didn't talk about this earlier, but imipenem relebactam has a higher barrier to resistance than ceftolozane, tazobactam, and Avicaz. And so once a patient gets exposed to these, their MICs could start to creep up potentially. You know, we've had ceftolozane, tazobactam resistance in several LVAD patients, several. And to me, Emi-Reli falls in line for the next one. Also, polymicrobial infections. We didn't talk about, you know, carbapenem-resistant Enterobacterialis today, but Emi-Reli certainly has a strong role there, you know? And so that polymicrobial infection, very much Emi-Reli could fit in there when you've got multiple resistance. I think Emi-Reli and Ceftriaxone kind of fit there. Ceftriaxone to me is next in line because it's got, I guess, more of the advantages of Acinetobacter and Stenotrophomonas. Some of those, for us, those are outlying organisms more so, where Ceftriaxone falls there for maybe those types of infections. But Emi-Reli is unique. I didn't mention Marrow-Weber on purpose. This is actually something we have a cascade reporting system, you know, but Marrow-Weber was actually being tested on some of these meropenem resistant pseudomonads. And, you know, some people were saying, well, it's always resistant. It's like, yes, it's always resistant because that's the mechanism for resistance. Marrow-Weber is not going to help you against the meropenem resistant isolates because it's a porin channel change, not AMP-C. It's either porin channel or efflux, and Weber-Bactam doesn't help you. So that one aside, I think Emi-Reli fits more so as the next line drug for me after ceftolozane, tazobactam, and in those polymicrobial infections, or when it's just resistant to others. We do test Emi-Reli as part of our automatic cascade so that it's already known. So if we have a surprise, we're not waiting another 2 days and another 2 days, because it's always going to be after 4 p.m. we call. The microlab's going to be not able to set it up that evening. And so they'll wait till the next day. It's not their fault. That's just the staffing model. Wait till the next day. Then that means another day waiting. And that's bad for an ICU patient. And that's why I tried to mention that data, even though it's observational. Starting the ceftolozane, tazobactam early had a positive effect in that cohort of patients in real world experience, as opposed to, and that makes sense, but it's still kind of neat to at least have that piece of data.
Thank you very, very much. Your insight from the bedside, I think, is extremely helpful on top of all your knowledge of the literature. So we really appreciate you. I see a shout out to you for all your great work in the chat. So thanks, Anthony.
Hey, Anthony.
I don't see any other questions. This was a great talk. We really, really, really appreciate you, and we appreciate you sharing your knowledge and your clinical experience with us. And we will have this talk uploaded on our YouTube channel once it gets recorded. And we ask everyone again, if you're seeking CE, please go ahead and complete your the CE survey within the next couple of weeks. Thank you again, Dr. Bookstaver, and we wish you all the best. And we hope all our attendees have enjoyed this talk.
Thank you all so much. Have a good one.
Too.
Bye-bye.